There are two forms of lupus. We have the systemic and then we have discoid lupus. Discoid lupus is not as rampant. In fact, it's rare and the involvement is only the skin, meaning the patient doesn't have systemic symptoms. That can still be serious, especially if the patient is young, because they'll have skin manifestations, they'll have a pretty bad rash on their skin. But we're only covering the most common type, which is systemic lupus. This falls under an autoimmune disorder, specifically under connective tissue disorders. This is very similar to rheumatoid arthritis, although this one I would say is more fatal compared to rheumatoid arthritis. So technical definition is chronic inflammatory autoimmune disorder. Affects every organ in the body because there is no organ in the body that doesn't have connective tissue. So this is a connective tissue disorder, an inflammatory connective tissue disorder. So name a body part that doesn't have connective tissues. None. We will fall apart without connective tissues. So let me name a few connective tissues. The skin. Your bones are connective tissue. Fascia is a connective tissue. The peritoneum, the pleura, the joints, the lining of organs. Okay, these are all connective tissues. Cartilages, okay, tendons, these are all connective tissues. Blood vessels are connective tissues. So there's no organ in the body that will not be affected by systemic lupus. Okay, so consider all of those connective tissues inflamed. That's what the patient's symptoms will be like. This is chronic, no cure, because it's autoimmune. Mostly women are affected here, 4 to 12 times more frequently in women. I honestly have never seen a lupus male patient. Okay, I've only seen women. How do I know? So we don't know the exact cause of lupus. Because we don't know the cause, therefore, no cure. We still have, because there's so many people afflicted with it, so there's foundations. There's a lupus foundation funded definitely by rich patients and their families. Let's go straight to the manifestations. We won't bother with the cause because we don't know what the cause is. We'll go to the figure, and then you can look at the patient's manifestations. Okay. So head to toe, because again, we're covered with connective tissue. So from our scalp all the way to your toes, you have manifestations. And including blood also. There will be blood problems because again, blood itself is a connective tissue. So from CNS, the patient will have some meningitis. The patient can have on the skin, there's a butterfly rash affecting that part of the face over the bridge of the nose and the upper cheeks. And it's quite ugly. Okay, it's red. There may be a picture on the textbook. So as mentioned already, there's pleuritis, pneumonitis. There can also be pericarditis. If you remember last semester, this is the non-infectious cause of pericarditis. You can have myocarditis as well. The number one organ that this attacks is the kidneys. You've heard of Selena Gomez, right? It's the most famous example of a patient who lost her kidneys because of lupus. We got osteoporosis, myositis. Now, the patient's main complaint, besides the rash on the face, is pain, specifically joint pain and muscle pain. This is debilitating. Because it's chronic, the patient can have good days with medication compliance. We will place the patient on autoimmune drugs, immunosuppressants, I mean. And because it's chronic, they can have flare-ups, they can have acute attacks, and then that will cause them to be hospitalized, especially if there's kidney involvement or if they have any of the cardiopulmonary problems like pericarditis or the pneumonitis, then they will be admitted to the hospital. There will be genitourinary effects as well as sexual activity, sexual function will also be affected. There will be lymphadenopathy, which resembles those with HIV, meaning they'll have swollen lymph nodes, and those are painful as well. So the discoid type is just the skin, none of the systemic involvement, which is the lesser of the two. But again, most cases are systemic. Number one complaint again is pain. So some of these patients will be misdiagnosed as having rheumatoid arthritis. Good thing though is that the treatment is similar to those of rheumatoid arthritis, although not very specific. You have to be accurately diagnosed for this to be treated correctly. Rheumatoid arthritis and SLE share some of the medications used in rheumatoid arthritis, but not very effective in lupus. So I won't repeat the manifestations. Let's go straight to the treatment. As far as diagnosis, there's no specific blood test to help the doctor diagnose, oh, this test shows that you have lupus. None. It's clinically diagnosed because the same tests done for RA are used to test for lupus. So there's no specific test to tell us that the patient has lupus. They also have positive rheumatoid factor. They have positive ANA antibody. So there's no easy diagnosis. Okay, so clinical expertise is necessary for the proper diagnosis. As already mentioned, these manifestations are very close in characteristics as those with rheumatoid arthritis. In fact, patients affected are the same as with rheumatoid arthritis. In RA, it was the 3rd to the 6th decade of life, correct? This one may start earlier. No, actually, RA started on the 2nd, right? 2nd decade. So about the same incidence, and then also mostly women. As already mentioned, the ANA and the RH factor are also positive in these patients, similar to RA. Let me repeat, SLE can be life-threatening. Unlike RA, not really life-threatening, but debilitating. This one, you can die from the complications, namely pericarditis, pneumonitis, and pleuritis, and also from acute kidney injury. But most cases, though, they'll have CKD, and these patients, unless they get a transplant, will end up on dialysis. So what's the treatment for us with any other autoimmune disorder? All we can do is put the patient on remission. Okay, we put them as symptom-free as possible for as long as possible, and that is achieved through immunosuppressant therapy. Besides keeping the symptoms away, we have to treat the pain. So pain management is important here. And because this is inflammatory in nature, what will be the most effective pain management here? And we already finished peptic ulcer disease. So you know already if these patients are taking NSAIDs 4 to 6 times a day, what will be added? Misoprostol. But again, what's the age group of these patients? So they childbearing age, right? So they have to be educated on the effects, okay? And proper birth control methods must be included in the plan. Because this is the only treatment for these patients, so questions on this test will be mostly on drugs, because that's all we were giving these patients, medications. We finished NSAIDs already from pain management chapter last semester, so we'll focus on the interleukin inhibitors as well as the immunomodulators. I won't have questions on monoclonal antibodies because these are very expensive medications. The regular Joe will not be able to afford these medications. Okay? Yes, same as rheumatoid arthritis treatments. Okay, so when we get to the table for the medications, they'll look familiar. Okay, you'll see, oh, I've seen that before in rheumatoid arthritis. Steroids are only given topically and also in cases of exacerbation. So if the patient has a flare-up and admitted to the hospital, then we use steroids. But to prevent, obviously, we don't want these patients to have Cushing's syndrome, correct? So steroids are not advised as a daily regimen. It's only used for exacerbations, for acute exacerbations.
That's the anti-malaria.
Say again? Hydro what?
Oh,
Hydrochloroquine. That's an anti-malaria drug. That was very famous. Right? Like I said, we'll look at it in the table with the medications, but the answer is yes. So here's hydroxychloroquine. You remember this very well in 2020, made famous by Trump and other right-wing groups. Okay. Now, how hydroxychloroquine helps is this antimalarial agent decreases to some extent the UV light absorption by the skin, because what's the largest organ of the body? And therefore, what is the largest connective tissue in the body? So therefore, what will trigger most flare-ups? Skin. The next most common trigger for an exacerbation is stress. So skin exposure to sunlight is number one, followed by stress. Stress can be in the form of an infection, surgery, pregnancy, anything stressful. Let's say Bailey has systemic lupus, so examination weeks will cause an exacerbation or potentially cause an exacerbation. So again, hydroxychloroquine, when taken for lupus, decreases the skin's rate of absorbing UV light. So therefore, it lessens the number of exacerbations. Again, because the drug has side effects, namely arrhythmias, so the doctor will decide how long the patient will be on hydroxychloroquine. So same immunosuppressants you've seen in last week from organ rejection is used here. Have you seen these already? Yeah, we did that last week. Yeah, so same medications. Priority complaints by the patient besides pain will be fatigue, then the rash on the skin, body image disturbance. Although for the skin, the patient, again, is young, correct? So especially if they're single and they're still looking for their forever partner, they can cover these because this can be discouraging for the potential partner because they, it's very evident. Okay, so they can cover that with cosmetics. Okay, cosmetics that contain moisturizers. Okay, that's what they recommend. So you can see, find your partner still, okay, even with lupus, and then find out later. Okay. Yes, the patient will have alopecia here because again, the scalp is a connective tissue. Okay, let's go to the medications now. Medications actually is yes under maybe it's under this chapter. Let me just mention Sjogren's syndrome briefly. Now, we're not covering this on our exam. However, patients with lupus and RA both of those patients usually have Sjogren's syndrome along with Raynaud's phenomenon also. Now, Sjogren's syndrome is the main manifestations is dryness. All your mucous membranes will be dry, starting from your mouth, your nose, your ears, including your GI and GU. So your urination and vaginal intercourse will be painful here because everything will be dry, right? Okay, here's your list of medications, although this is not complete. Table 34-2. Similar, again, to RA medications, although most patients with lupus are not given, for example, they're not on methotrexate. Okay, so methotrexate is more for RA, but the rest of the medications are used for lupus. Okay? So same TNF blockers, same interleukin 1s, interleukin 6 medications, okay, are used for RA. So we'll use the same table. And for steroids, again, when are steroids used in lupus?
Acute exacerbation.
For acute flare-ups. Okay, so if they have acute attacks, then they'll be placed on high-dose steroids for a few weeks.
You get an inpatient, or you take it home as well?
Hmm?
You get it outpatient too?
Yes, because we won't keep them in the hospital for several weeks. So they'll be in the hospital for monitoring for kidney function because during an exacerbation, it's usually the kidneys that will suffer. We want to closely monitor them for AKI, and then we'll use steroids. And then of course, after we make sure the steroids are doing their job, then we can send them home on a tapering dose of oral steroids. And okay, let's finish the for exercises. So similar again, no different from RA. Table 34-3 are the recommended exercise for these patients. Now, rest is advised, of course, because there's fatigue, especially during the exacerbation episodes. So swimming, walking would be your aerobic exercise. Make sure you, of course, you know how to swim. Yes. Not necessarily. Because appetite is not really affected unless they develop depression, then yes. Now, pregnancy, because these patients are childbearing age, they can get pregnant. Okay, so the problem is pregnancy is a stressor. Yeah. And therefore, is there a chance of a flare-up during pregnancy? Okay. Now, how we educate the patient is, let's say they got pregnant. Okay, the birth control did not work. Doctor will simply adjust the medications, which medications are teratogenic, then they'll be stopped, okay, momentarily while the patient is pregnant. We'll use other options that are non-teratogenic. If the patient decides to, let's say, oh, I'll terminate the pregnancy. So just give them information on what's the difference between terminating the pregnancy or getting an abortion versus carrying the baby to full term. Evidence shows there's really no difference. If they terminate the pregnancy, they can still have a flare-up. If they take it to term and give birth, they still have the same risk of a flare-up. So at least they have information on what do they want to do, okay? Because they're going to have a flare-up either way. Okay, so meaning terminating it doesn't really stop a flare-up. Okay, so at least they're educated, they're informed about the data. We can only give them facts. Okay, so this is the facts, and then you decide. You're the you're the boss. You're the woman, and so it's up to you. Like I said, because this is a sad disorder to have for such young women, so there will be depression. Okay, so they'll have anxiety, depression. So some of the interventions here mentioned will be, of course, they'll be put on antidepressants, some sleep aids for the insomnia, and also ways to reduce stress. Like these will not help, right, with the insomnia. Okay, so just reminding them of things they may not be thinking about when they're in that scenario. It's easy for us because we're not the ones affected. So in nursing, I've always believed, that it's better to give than to receive. You agree? It's better to give care, right, than to receive care. Um, for the joint pain, review the interventions mentioned under RA because it's really the same. So if the patient complains of the joint pain, what did we tell the RA patient? Showers or baths? Showers. Was it warm or cold? Warm showers. Okay, so to relieve again, because this joint pain and stiffness and swelling is the same, exactly the same as in RA. So there's no difference. Why do we not advise a bath? Why do we not advise a bath? They may not be able to get up from the tub. Okay? At least with a shower, you're already standing up and just walk out of the shower. Hmm? Well, they walked in there, so they can walk out.